Great. Thanks very much. I'm very excited to be a part of this expert group meeting to discuss improving progress on health for all. And my goal for this presentation is to talk about digital technologies and how we can leverage digital technologies to achieve progress on health for all. As a bit of background, I'm a professor of demography, but I have also a lot of interest in how digital technologies and digitalization is affecting the achievement of the SDGs, but also how digital technologies can provide new data sources for measuring and filling data gaps in relation to SDG monitoring. And so I want to sort of sketch out some ideas and also provide some evidence based on the research on how, specifically when we think about health in the context of the SDGs, where digital technologies might fit in. So to start out, I want to sort of state the obvious, which is that digital technologies are really ubiquitous. The digital revolution has swept the world in the last 25 years. The diffusion of technology has occurred really across all global regions. And in some ways, this is quite staggering that this technological infrastructure has swept the world. The levels of technology subscriptions per capita, as shown here in the data by the ITU, of course, they vary across the world still, and there are differences between Europe and Africa and Asia, for example, in technology subscriptions per capita, here talking about internet and mobile technologies. But the trend is very similar. It's one of rapid diffusion. And technology infrastructure has often improved faster than many other infrastructures, such as, for example, sanitation infrastructures. And I think that's quite striking when we think about regions of the world, such as Africa or even parts of South Asia, where other types of telecommunication technologies, such as landlines, have really never been as widespread as mobile has, such that first large-scale telecommunication infrastructure and internet technology is largely mobile. So this digital revolution is really an interesting and obviously a very striking phenomenon within the last 25 years, but then it is also very much a social transformation of our world, of our societies. And technology has, at least theoretically, the potential to empower marginalized populations because it provides efficient, cost-effective ways of improving information access, of providing access to services, as well as just connecting people. And this idea is perhaps not new in the context of the global SDGs. For example, SDG 5 on gender equality pledges to enhance the use of ICTs to promote the empowerment of women. Similarly, there's this empowerment idea also in 2018, when world governments unanimously call upon the World Health Assembly for a resolution to adopt a sort of digital health strategy to improve universal health coverage. And subsequently, the WHO has released guidelines on using mobile phones, for example, to improve access to health services in LMICs. So there's evidence of thinking about technology as a mechanism, as a vehicle for improving the prospects of marginalized populations that is quite cross-cutting across multiple SDGs, including those relevant to health. Although to my mind, I think the question is, this is theoretically a very promising idea, but really what is the empirical evidence about technology helping to reduce inequalities or to improve marginalized populations in access to SDGs and in access to health or other kinds of well-being enhancing objectives. So then this brings us to the second feature of digital technologies, which is that this digital revolution has obviously transformed our populations in terms of changing how we interact and communicate and access services, but also the very use of digital technologies such as the internet and mobile phones has generated new streams of data and tools for data collection and monitoring that have the potential to provide real-time information for SDGs and for health systems. So if we think about the digital revolution and digitalization, there is both the sort of social as well as this data opportunity that it presents that I'm going to briefly talk about in this presentation. So I want to focus a lot of my presentation on thinking about particularly about mobile phones. Um, and mobile phones can impact on health through various mechanisms, three of which are outlined here. First is that we can think of mobile phones as improving access to private information in particular because of the nature of the device, as well as access to services. And there is already a lot of discussion, such as in the WHO strategy that I was talking about. There's a lot of excitement about mHealth and eHealth as tools that can improve, for example, health behaviors and health seeking within populations in cost-effective ways. Although interestingly, even though there's been a lot said about mHealth, the burden of evidence, I would say, or the standard of evidence is still quite mixed about the impacts of mHealth. Although the one domain where I think mHealth has shown potential is in particularly service seeking around antenatal care and around reproductive and sexual health. And there are some cases where this has also been positive and been able to be scaled up, such as in maternal messaging programs in contexts such as India and Kenya. Another way in which mobile phones is relevant from a service perspective and financial infrastructure perspective is, of course, mobile money, which, if we think about costs and accessing and having financial resources to be able to pay for shocks, for example, those linked to illness or ill health, then mobile money can be a way of smoothing consumption and also enabling a type of financial stability within households and families, and also to be able to gain from networks financial resources swiftly and efficiently. Mobile phones, of course, provide also better connectivity and access to networks. And they also provide exposure to the life of others, including much more globalized media content, which could have impacts also for health behaviors and also for how we learn about different things. For example, how we might learn about contraception. So if we think about each of these mechanisms separately, we know that, as I said already, mobile or digital health strategies are in some ways being adopted in different ways, although often in unstandardized ways. And we can think of mobile or digital health if we think about improving access to services and to health systems in particular. Mobile or digital health can have different types of functionalities. It can help in improving information and behavior change, provide also technical solutions for the provision of care, such as remote diagnostics, can also provide better communication between health workers, particularly in areas where systems otherwise have limitations in terms of capacity, and also provide better systems for registration and recording. And as I said already, pilot randomized controlled trials do point to success of actually very low-tech solutions such as SMS or voice calls in improving knowledge, especially around reproductive and maternal health in LMICs. And so there is clearly some evidence that this can work, but they're really low-tech solutions such as SMS or voice messaging that seems to be effective. And for specific things, like as I said, for antenatal care seeking, as well as for postpartum care, there's evidence this can be effective. I already talked about the impacts of mobile money. But as I said, I think one of the bigger issues in this area is how do we think about the population level impacts and of these different mechanisms linked to improved information as well as access to services. How should we be thinking about population level impacts and scaling up these solutions? For example, mHealth solutions is, I think, still very open territory. We think about if we think about the next mechanism, which is better connectivity and access to networks vis-a-vis mobile phones, there is evidence that appointment reminders and treatment adherence via SMSs obviously is valuable, again, through better connectivity. People are more reachable, but they can also share and learn from each other. Peer-to-peer exchange can be amplified through social networks, again, through better connectivity. But on the other hand, social networks can also exacerbate harms. And we've discussed a bit already in this meeting how excess connectivity, or there can also be vulnerability because of wider participation in social networks. And of course, there's evidence that GBV can also move online. So there's technology facilitated gender-based violence. And if we think also about media effects and exposure to media, there is really also potentially theoretically ambiguous effects here. We can have improved health information, but we can also have misinformation that can be circulated via the internet and internet technologies. And I think COVID-19 was a very, very relevant case study of really misinformation dynamics as well. So in some of our work, we've been looking at the population level impacts of mobile phone ownership, particularly among women in the African context and the South Asian context, on outcomes linked to women's empowerment and sexual and reproductive health. And here we're thinking beyond just sort of simple health. We're just thinking about how does owning a mobile phone impact on decision making around contraception, equality in decision making within the household for women, surrounding health and large purchases, as well as their own mobility, using modern contraception and knowing about where to access health linked to HIV and antenatal care. And generally, even when we put in a battery of control variables linked to education, wealth, other types of media, and control for local development, we still find there is a net effect for having a mobile phone. And I'm going to skip a bit explaining our empirical strategy and focus on this part, which is that the marginal effect of this mobile ownership seems to be the largest in those areas where local development or other types of infrastructure are lacking, right? So what this shows is that around outcomes linked particularly to women's empowerment, sexual and reproductive health, we see greater payoffs of digital technologies and in areas where other types of infrastructure are often lacking, which does show that there is some type of, through various mechanisms linked to information seeking, through improved decision-making power, as well as potentially through mechanisms such as financial smoothing around large shocks, such as health shocks. This can be a powerful tool. There are yet bottlenecks. So as I'm saying, mobile phones and digital technologies can promote health knowledge, women's empowerment, and health-seeking behaviors. And these are more than just sort of targeted health interventions, because when we look at this at the population level too, we're seeing evidence for some impacts in LMICs. But what are the bottlenecks? So in work that my team and I have been doing, we've also been looking at how access to technologies is demographically stratified, particularly by gender. We find that particularly in sub-Saharan Africa and in South Asia, women are still much less likely to own mobile phones and use the internet. And while there is some progress on this, more in South Asia than in sub-Saharan Africa for the moment, these digital gender gaps still are pervasive. And when we look at specific use cases as well, for example, using a mobile phone for financial transactions or for family planning, as these data from the demographic and health surveys show, across South Asia and sub-Saharan Africa, we still see that while there is clearly evidence that populations are beginning to use mobile phones for these kinds of activities, this kind of use case still has a long way to go. There's still large fractions of the population that have a mobile phone, but are not necessarily using these services linked to mobile phones. We have also other issues such as uneven and incomplete adoption. Already I've mentioned the issue of gender and gender digital divides, but also there's a lot of inequality in adoption within urban and rural areas and subnationally. Here's an example from Nigeria, where Lagos has over 55% of women using the internet, whereas in the northern province of Sokoto, we have 2% who are using the internet. So there's large variation. We also find that women are often unable to use or much more likely to use mobile phones in a shared way rather than in exclusive individual ownership because norms limit their access. And when women and particularly marginalized populations such as low socioeconomic status groups have mobile phones, they're much more likely to be SIM switchers. So if, for example, we were planning a health intervention that required a stable mobile number, we lose these populations more because they switch SIMs much more because of income constraints. So the last part, I want to just sketch out some ideas of how the new kinds of data generated by the digital revolution can be helpful for monitoring the SDGs and within health systems more broadly. So as I've said, digital technologies provide new streams of data, which together with AI or machine learning approaches can help us map social indicators at high resolution, which are relevant also for identifying the vulnerable. And here, this has been shown quite effectively in the poverty mapping literature, and it could also be relevant when thinking about health coverage. The digital technologies also provide better systems for registering and monitoring vital events. And thirdly, digital technologies provide opportunities for crowdsourced data collection and real-time data collection, such as through mobile phone surveys or social media targeted surveys. And these really became quite widespread and were used across research communities as well as policy communities, particularly during COVID-19. So here's an example of how the linkage of multiple traditional and non-traditional data, so from surveys as well as satellite data, can help us shed light and measure social inequalities or health inequalities, here measured in terms of those who can access a health service within an hour of travel time at high spatial resolution. But what these maps also show is there's a lot of variability across different sources, which also shows that while these data sources have proliferated, there is still a lot of variability and there's still a lot of knowledge to be gleaned about how to integrate traditional and non-traditional data sources effectively and understand the uncertainty in the estimates that they generate. Similarly, phone-based approaches in the poverty mapping literature have been used to predict wealth and consumption in a way that allows us to target aid more effectively. And some evidence suggests that using phone records, so mobile phone metadata, can help us predict income and consumption levels within a household, which in turn can help us target aid to those who are most vulnerable and minimize errors of inclusion and errors of exclusion through this kind of targeting. And lastly, mobile phone surveys, as I said, have become ubiquitous during the pandemic, and they were used, for example, in a series of World Bank surveys to estimate the socioeconomic impact of the pandemic, were used by calling people because other forms of surveying was difficult during the pandemic. Mobile phone surveys were used, for example, to estimate the prevalence of foregone care, which in this analysis occurred really across different country groupings, including low as well as upper middle income countries, and varied across regions. But there was considerable foregone care during the pandemic that these surveys revealed. Similarly, work has used mobile phone surveys to track food insecurity during the COVID-19 pandemic, where again, mobile phone surveys were for providing high frequency insights in key socioeconomic domains in the context of COVID-19. So just to summarize, the digital revolution has both social and data implications, which is relevant for thinking about how to promote health for all. Within health systems, I think we still need to think about how we can scale up and integrate digital within systems rather than thinking of digital as standalone solutions. But when we think about digital technologies, it's much more than just M or E health. It's important to think more broadly about how populations are interacting with technologies in ways that are relevant for health behaviors and health seeking through the various mechanisms in which technologies are influencing our lives. There is evidence that there's larger payoffs, particularly of mobile phones for marginalized groups in areas where other infrastructure may be lacking. But some of these impacts are, of course, not as, but digital divides persist, which of course hamper the wider impacts of mobile technologies. And in particular, gender digital divides are quite notable still in sub-Saharan Africa and South Asia. And digital technologies also provide new streams of data, which is also relevant for monitoring the SDGs and for monitoring access to health. But a lot of this data is still constrained in terms of access because it's kept in the hands of often technology companies, and data sharing standards are still uneven, and access is often constrained as a result. So I'll conclude there, and thanks very much. Look forward to the discussion.